So moving towards the next session, this is going to be a debate, and this debate is regarding oligometastatic CA prostate, believe it or not. And it is my great honor, great pleasure to invite Dr. VINEET TALWAR sir. Before introducing anything else, I would like to tell sir has been my thesis guide. Sir has, it is not wrong if I tell you, sir has awarded me the degree of medical oncology, and he is the director of medical oncology at Rajiv Gandhi Cancer Institute. I would like to welcome Dr. VINEET TALWAR sir, and I would like him to welcome Dr. VEDANG Murthy sir and Dr. T.P. Sir. Over to you, sir.
Kshitij, thank you so much. I don't deserve such words. And at the outset, I would like to thank you and Chirag for giving me this opportunity for a burning topic, oligometastatic prostate cancer, believe it or not. So we have Dr. VEDANG Murthy for the motion. I think he's a professor in TATA Memorial Center in the Department of Radiation Oncology. Needs no introduction. Over to you, VEDANG, please.
Thank you, sir. Thank you, sir, for the introduction, and thank you for the invitation. I have about 7 minutes to talk about this hot but a little vague topic, believe it or not. And to set the motion, I will set some rules. And believe it or not means I will try to prove that I believe oligometastatic is a thing, and in other words, it is different from polymetastatic disease. So let's see what we can do. Why are we debating this? Because classical patient A, patient B, you can see a few mets, multiple mets. Is it really something that we should be treating these patients in the same way? Should they be classified together? Will they have different outcomes? Those are the questions we ask. And as we treat more and more patients and detect more and more patients using more and more imaging, we want to do more. Our patients want us to do more, and we see that every day in the clinic. And the question is, and also we have the ability to do more with the newer therapies that are available, including high precision radiotherapy, for which most of the evidence now exists. I can just say, well, we don't have to debate. The global guidelines now accept this as a thing, and there is very good evidence that we should offer treatment in so-called low volume disease. So, but that would not be fun. So let us see what the group of experts who got together in 2017 in what is called the Advanced Prostate Cancer Consensus Conference thought about oligometastatic disease. And this is 20 years after it was first described by Weisselbaum. Actually, about 65% said that it should be defined only if there is limited nodal or bone metastasis that is amenable to ablation. So there was not even a definition at that time, just 4 years back. And of those who believed that it should be defined this way, only 66% said that up to 3 are called oligometastasis. So to have consensus, you had to reach 75% of the panelists calling it oligo. So we didn't have much in 2017. But something changed in 2019. The panel voted, 75% voted that. Can I ask people to mute their mic? So that focal treatment should be offered for all oligometastatic lesions. That is a big jump in 2 years. And in fact, 98% said that there's an overall survival benefit if you treat oligometastatic or low volume patients. So what happened? Why did this change happen? Obviously, some evidence came in. And before I go into that, let me set some rules. I'm only talking about de novo or synchronous oligometastatic disease, which means which has been diagnosed upfront, newly diagnosed prostate cancer and has a couple of mets, or previously treated prostate cancer and has a few mets. So this is the scenario I'm talking about. There is oligo recurrence, oligo progression. I'm not going to go into that. Also, I'll be using oligometastasis and the charted definition of low burden metastasis interchangeably, because that is how the evidence is right now. Why do we want to treat oligometastatic prostate cancer? The hypothesis is if you catch it at that stage, you can either delay or halt the progression to polymetastatic disease, which is invariably fatal. So that is the hope that we have. And there's a lot of studies on biology looking at the differences in biology, but I'm not going to go into that for the lack of time. I'm going to show you proof, clinical evidence that there is something in oligometastasis that is different from polymetastatic. And I'm going to talk about primary directed therapy and metastatic directed therapy. And I'm going to show you only 2 trials in each scenario. Starting with the most famous trial that probably set this apart, the Stampede. 2,000 patients randomized to systemic therapy or systemic therapy and radiotherapy to the prostate. On the right, if you see, when they looked at the so-called high metastatic burden by overall survival by the charted definition, there was no benefit of adding radiotherapy to the prostate. But something is happening when there is low metastatic burden, and that something is what is actually calling out to say, look, I'm different, which is what I'm trying to prove. Now, remember that was low metastatic burden by charted. What about numbers? A very elegant analysis of the secondary analysis of Stampede published last year tried to see if you can figure out by number of mets if there is benefit of local radiotherapy. And they found, you can see at the bottom, if there are 4 or more bone metastasis, there is absolutely no difference whether you treat the prostate or not. But if there are 3 or fewer or only regional, the overall survival is improved by adding radiotherapy. Again, the low burden converted to numbers of 3 or fewer. There seems to be something happening here in terms of numbers. Another trial, very similar but much smaller, called HORAD. Many of you have heard about this. 432 patients, systemic therapy or systemic therapy plus RT. No difference overall. But if you look at the subset, and this was because smaller, 160 patients had less than 5 metastases, and the hazard ratio for overall survival was 0.68. So again, something is happening when there are fewer mets and you treat the prostate. I'll move on to metastatic directed therapy. Very interesting. Small trial called STOMP, randomized. These are patients who are recurrent, previously treated, and they have had a biochemical relapse, and up to 3 mets. They are either given nothing to avoid ADT, or all the sites of mets are treated. And this was updated recently a few months ago, the 5-year update. Big difference in ADT-free survival, which is an important endpoint in metastatic patients, and CRPC-free survival, a 20% difference at 5 years. In fact, very interestingly, at 5 years, 85% are overall survival, and there is even a chance that some of these are probably cured. And that is the beauty of this oligometastatic disease. This will not happen in polymetastatic disease. And finally, I'll show you another very similar trial called Oriole. Small trial, phase 2, very similar, 1 to 3 mets after primary treatment. You can see the rate of progression at 6 months is more than double if you treat the mets. PFS is not yet reached for if you treat the mets, whereas 5.5 months for if you don't. So, and surprisingly, and not surprisingly to me, but no grade 3 toxicity. So this was not even the most interesting part of Oriole. They did an analysis which is very interesting, and this is my last slide. They looked at a group, all patients' mutation status, and they classified certain mutations as high-risk mutations, and others as low risk. So the patients who had high-risk mutations versus those who had other mutations. There was no difference if you treat SBRT to the mets if the mutations are present, but if these high-risk mutations are not there, a big difference in adding metastatic therapy. So clearly, even biology is shouting out that, look, there is something, a difference between oligo and polymetastatic disease. So it is an established paradigm, including in the guidelines. There are specific treatment recommendations. The outcomes are clearly better, and the evidence is out there. You may or may not believe it, but I certainly do. Thank you so much.
Thank you, sir, for those for this great academic information, sir. So I would like to request Dr. T.P. SAHOO, sir, to speak against the motion.
Thank you, organizers, and really, I
So
echo
Dr.
Vedant.
SAHOO is Dr. SAHOO is a close friend, and he is a senior medical oncologist from BHOPAL. He is an expert in debate. So let's see what he comes out with.
I am also close friend. Yaar, aise kya bol rahe ho?
We are all close friends.
So the only thing here is that I can really echo Vedant's thing is it's a vague topic, and really the point of debate is really a little blurred here. So I will try to do a good job. I'll try to do it for the sake of debate. And I really think that the points of debate are really very blurred here. You don't have brownie points on each side of it, actually. And there will be some points both of us will be speaking. But there are some things which I'll tell you. And what I had actually, it was so blurred that I had to call back Chirag Bhai and tell me, what exactly do you want in this debate? And that was that blurred that was. So what I got from speaking to Chirag sir was that oligometastatic, when you look at it, do you feel that you are going to cure this patient? And definitely I echo the sentiments of my friend that definitely oligometastatic, we have heard it in CRC, we have heard it in RCC, we have heard it in a lot of cancers, breast cancer also. So are they different? And my point as a medical oncologist is, can I do something and cure them? And to that, I will just tell Vedang, who's a very good friend, dear friend, I cannot be like him. I cannot run marathons like him, but I can debate like him. So are you serious, Vedang? And you are a very rational guy. You always talks and speaks sense. But this last 5 minutes was something which I found little bit of sense, not the whole thing. So let's come down to the NCI. And I just pulled down after I spoke with Chirag sir, what is the difference in cure and remission? And this is 2001, very new things. Cure means there are no traces of a cancer treatment and cancer after treatment, and it will never come back. It's a very emphatic statement. It will never come back. And the other word is remission. So if you're speaking of remission, I'm okay with it. If you're speaking of cure in oligometastatic, sorry, I'm not at all okay with it. I'll tell you what I think the oligometastatic disease is, and this is where it is. So look at how it has evolved. And I totally would use some of the slides which Dr. Vedant has used. And if you look at the definition, and if you go to the ESMO, which was presented last year, there really no consensus of a definition of oligometastatic. The generic definition, what he spoke, 1995, and just think what they were hypothetical. It's a transitional state. So I think in 2021, when I saw my last slide, this exactly thing will happen. It is still hypothetical, and it's still a transitional state from a localized disease to a highly metastatic disease. The only thing you can do is, because the burden is less, you could delay, but you cannot probably cure it. And the debate about the number of metastases, Dr. Vedang rightly put up, there is still no consensus, less than 3, less than 5, but most of the trials have taken less than 5. Although people believe that less than 3 would be the better definition, because as I tell, if you have a comparison less than 1 and less than 3, less than 1 disease is going to do better, because the load of the disease is always less. So that will always be there. But still, what would be defined as oligometastatic, no one knows, but the major consensus still remains less than 5. The main problem happens the diagnosis. Whichever trial Dr. Vedang showed and whichever trial I am showing did not use the PMSA or PSMA PET scan. All use the bone scan. So are we really defining, and did we pick up the really metastatic oligometastatic disease is the question. So if you really want to do it, the way we diagnose this prostate cancers are going to be important. And it is important that we use something that is highly sensitive. But if you look as a PMSA PET scans, you look at it, it really takes away. And there was a data that lot of this metastatic disease, when you do a high quality scans, then they really turn out to be non-metastatic. So I think the diagnostic way modality is so important to define oligometastatic. There is a background noise, if someone can. Now, okay. Now coming down to the HORA trial, which he showed, it did not show a significant difference in overall survival. That was the take-home message, because as medical oncologists, we have been trained for the looking at the primary objective. 432, 216 to androgen deprivation, 216 to the androgen deprivation and the RT. Less than 5 lesions, around 40%, and more towards the RT arm. And look at it, not the difference in the intent to treat population. And if you look at the meta-analysis, look at the forest plot, the way I have learned forest plot over the last few years, you cannot tell that less than 5 or more than 5, it is going to be any different. Only you can tell there's a trend. You do not take conclusions out of it. Now come back to the stampede, which is the most spoken about, because all the data which we will find except for stampede and the HORAD has been retrospective. These are 2 prospective trials actually with RT to the local site. And this trial again in all patients was a negative trial. But let's come down to what Dr. VEDANG is speaking about and look at this low burden metastatic disease, which is approximately 42 to 43% of the total patient load. And this is the data. If you look at the OS, there was a difference. The curves did separate. It was not, it is just separate, it different from the high metastatic disease. And the failure-free survival was also different. But do you know that median follow-up was 37 months, which is shorter than the median survival, Dr. Vedant. So you are presuming the survivals. So the median follow-up was 37 months, and that was shorter than the median survival, that was 46 months quoted in the trial. So it was estimated. And look at the criteria. We spoke of 3. You did tell me that 3 was the cutoff for you. But if you look at, they took the charted trial, and someone has to read the charted trial, how they defined it. You had to have 4 or bone metastasis, means you can have 10 metastases in the spinal cord, in the vertebrae. If not one of them is outside, then it still would be a low risk. So is that fine with you? So the definition of oligometastatic as per the stampede still is a big issue. And there is, so this is something very, 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 very important. Last point which I want to tell you is that the trial was run in UK and Switzerland. And most of the patients, now we know docetaxel helps. And most of the patients did not receive docetaxel with androgen deprivation therapy. So that would have impacted the way. So does radiotherapy to the primary prostate helps? It's a very difficult thing to say with so much of things to tell. Now let us look at the point is, are we curing this oligometastatic disease? Just look at these 2 points, the PFS, the OS, and the prostate specific survival. You know the difference between the ADT and the RT arm and the non-RT arm? 3 to 4%. It basically delays the inevitable. You're not going to cure that. Look across the OS, the PFS, and the prostate cancer specific survival. The difference in the low metastatic disease, so-called low metastatic disease load is only 3 to 4%. And lastly, as I echo your thoughts, biology is the king. And this is what it is. If you have a de novo metastatic prostate cancer, it is very, very bad. There are data to that effect that they do much, much, much poorer to primary progressive metastatic disease. And I totally, this is what it is. So I totally echo your sentiments. We have to find the right biology. And if you cannot define that, you are never going to tell with the terms that it only 2, only 3, only 5, like putting the chartered criteria, you're never going to come to a conclusion for it. So biology rules the roost. And look at the number of publications. I heard one intelligent man telling me in my primitive years that when I was developing as a medical oncologist, the more trials you see, you believe that you are failing. If there's something is very, very sure, then you would not spend money on that. So look at the number of publications. It is 113. It's only increasing. Means the world is still not convinced about this. We do not know what it is, and we are still searching for an answer. And this is what you also quoted, and I have taken a clue from that. This is the ASCO education booklet, and it rightly defines, and I totally agree with it. Is it a shrinking subset or an opportunity for cure? This is the point which I will end the debate with, and this is that point which you showed. I look at it a very different way. This is only a transition. This is a transition from a patient who is curable with localized disease to someone who has a metastatic widespread disease. It's just a point of transition. You just picked it up because you did a good quality PET scan. That's it. It is nothing different. You do the scans more, you will pick up this more. But are you going to cure it? No, it is not. So take home message. Oligometastatic is a state of disease of prostate cancer in transition. It is nothing different than a metastatic disease. Ultimately, all will fail eventually. The PFS and OS is definitely better as per the trials at this point. Statistics, yes, it looks little better if you add RT, especially for those very low volume or probably the less than 3. I did not speak about the targeting the metastatic site because you only answered the point of debate. Phase 2 trials, both of them, 40-50 patients. And I learned one thing: when you see the graphs falling steeply, you know that there were 2 or 3 or 10 or 20 patients. That is where it is. The bigger trials, the graph do not fall that way. When you have a long falling graph, then you know that you need bigger trials. So I would not read much into the phase 2 trials. And what I feel, but cure is still a distant from reality. So my friend, please, it's time to get real. Please get out of this virtual world and don't look into that. The man is standing on the bottle. He's standing far away from the bottle somewhere near the camera. And this is the illusion. So we have to get out of the illusion. Thank you. Thank you, everyone.
Thank you, Vedang, and thank you, Sahu. You put your points very nicely. It can be argued both ways, but one consensus is that we don't know what is the actual number in oligometastasis, from 3, 4, 5, or less than 2. But one thing is sure, that there are no visceral metastases whenever you say that it is oligometastasis. The other thing is whether it is de novo versus recurrent versus new. How do they behave? Do they behave the same or not? The answer to that, Vedang has showed 2 prospective studies. One was the HORADS trial, which was a small trial. And in that, the no pelvic lymph nodes were addressed. That was one. And second was that, as Sahu had mentioned, bone scan was used as the point of defining whether it is oligometastatic or not. Even in the other trial, the Stampede trial, it is only the PFS benefit which is there. There is no OS benefit. Younger population was used who had lower comorbidities, and even 6 months prior use of ADT was used. So there is a dichotomy. There's another trial, which is the Shanghai trial, which is going to address this. And it has shown that there is a radiographic progression-free survival and not the overall survival per se. Having said that, the question is very clear that the imaging modality which was used for these trials against the PSMA PET, which is used conventionally now, how would you say that this is an oligometastatic disease or otherwise? So at the end of the day, as both of them have said, the biology rules the roost, and that obviously will give us an insight as to how to go about treating these patients. Whether to believe or not is not the issue. Issue is that you have to keep into account, if the biology of disease is slow, then definitely you can go ahead treating it locally. Otherwise, you have to take it with a pinch of salt. With this, I thank the organizers for giving me this point.
Thank you, Dr. Talwar, for your enlightening remarks. And I would like to thank Dr. Vedang Murthy sir and Dr. T.P. Sahu sir for really setting the tone for this webinar.